Langsung ke main Zoom ya. Ibu-ibu, bapak-bapak, iya jadwal kan.
Selalu. Terima kasih Pak Putu.
Recording in progress.
Selamat malam Pak Yusuf, Mbak Puspa. Ini ternyata baru kita berempat saja yang join. Ini sudah langsung dihubungkan ke main Zoom yang di Makau oleh Beli Putu. Nanti mungkin kalau pesertanya tidak ada sampai acaranya dimulai, nanti mungkin kita ini aja ya, sambil jalan aja nanti disapa-sapanya lewat chat aja ya Mbak Puspa ya Pak Yusuf ya gimana? Untuk mengingatkan absensi dan pertanyaan itu nanti mungkin via kolom chat saja kalau ternyata sudah terlanjur mulai di main Zoom. Baik.
Pelado que belo, a roupa suja, está crescendo, galera, a nhonya cantar. Ela que belo a roupa suja Ficar que dizem Janela a nhonya cantar
对，如果可以，时间上可以，他们就会赶快动作。
Get ready for year-round fun in Macau. January 2024. Cheers! New year, many exciting programs are coming your way. Illuminations continue to light up Macau. Thrilling sailboat racing. There's also a series of international concerts waiting for you. This January, let's experience Macau.
A very warm welcome to each and one of you. Hi, everyone from Asia and to all our audiences from all parts of the world, and most especially to everyone from Macau. This is CPD ASIA, the online continuing professional development platform for Asian Radiologic Technology Societies. And hosting the 33rd CPD ASIA is the Macau Radiologic Technologists Association, MRTA. I am Peachy Luna, the CPD ASIA Secretary General and your CPD ASIA program host. We are live streaming on YouTube. You can search MSR or PARI and or VART channels so you can watch us live and or watch a replay. This CPD Asia is highly supported and raised by member societies, presidents, all their officers and their representatives. Let us greet and welcome Ms. Cora Nang, the chairman of Macau Radiological Technologists Association, MRTA.
Hello, welcome everybody to join the 33rd Asia CPD hosted by our society. Welcome.
We also have President of Perhimpunan Radiographer Indonesia, Indonesian Society of Radiographers, or PARI, Dr. Giek Sudianto.
Hello, Vichy and everybody, Fernando, Cora, and the committee, and all president. Hello.
Also with us is President of Vietnam Association of Radiologic Technologists, VART, President Thai Van Doc.
Hello, everybody. Hello, everybody.
Also with us is President of Hong Kong Radiographers Association, and Mr. Nang Tat Ning.
Hello, everyone. Good evening. Welcome to this webinar, Asia CPD program. Enjoy tonight.
Yes, and with us also is President Chun Yuan-Tu of the Taiwan Association of Medical Radiation Technologists, TAMRT.
Hello everyone, good evening. Nice to meet you.
And with us also first as our president is Chung.
Good evening, everyone, and thank you to MRTA friends for putting together tonight's program. Looking forward to the presentations tonight.
Also here is the president of Malaysian Society of Radiographers, MSR, President Mr. Sawal Marsait.
Hello, everyone. Happy New Year. Still early of 2024. Hello.
We've received greetings from President of Indian Society of Radiographers, President of Society of Radiological Technologists, Sri Lanka. We also have the greetings from the President of Japan Association of Radiologic Technologists, JART, from the President of Philippine Association of Radiologic Technologists. We also have received the greetings from President Sophie Lee of the Association of Cambodian Radiological Technologists and the President of Palestinian Association of Medical Radiation Technologists. So we have also invited panelists who will be joining us later together with the presidents during the Q&A session. For now, let me humbly ask everyone to please open their camera for a short photo op. For now, let me humbly ask everyone to
Hello, Christine.
For now, let me ask everyone All right, thank you very much, dear presidents and officers and our panelists. They'll be joining us again later during the Q&A session. So ladies and gentlemen, before we start the program, may I humbly request to give us the welcome message. Let us welcome the President of Macau Radiological Technologists Association, MRTA, President Fernando Koch.
Hello, good evening, everyone, and Happy New Year. Welcome to the 33 online Asia CPD program in conjunction with the 34 CPD program of the MRTA. It is a pleasure to have you all to join us for this year, the first online CPD. Our online Asia CPD program has been serving as a remarkable platform for the radiological technology from across Asia to come together, learn together, and grow together. I would like to extend my appreciation to all our Asia CPD member societies for their long-term collaboration and support in organizing this program. Let us make the most of this opportunity to expand our expertise, network peers, and contribute to the advance of radiological technology. Thank you, and enjoy tonight. Thank you.
Thank you so much for that warm welcome. Ladies and gentlemen, we just heard the MRTA President Fernando Koch. So beginning the session now, let me introduce to you briefly our session moderator from MRTA. He is the Academic Director of Macau Radiological Technologists Association in Macau, China, and a radiologic technologist of the Department of Radiology of S. Januario Hospital Health Bureau, Macau. Ladies and gentlemen, please welcome Edwin Au.
Hello, everyone. I'm Edwin Au from MRTA, and I'm the moderator of the academic section. So today we have two topics. The first topic is about the quality control. This is the part that we sometimes overlook in our daily work. So today I'm very pleased that we have the speaker from Macau, who is Ms. Anna Yang Peng. She is the financial director of the MRTA and also a very senior radiological technologist in our Macau government hospital. Today, her topic is the introduction to quality assurance and quality control of medical in Macau Public Hospital. Let's welcome Ms. Anna Yang Peng.
Good evening, everyone. I'm Anna Yang Peng, Director of Finance of the Macau Radiological Technologists Association. Today, I would like to share about the introduction to quality assurance and quality control of medical imaging in Macau Public Hospital to you. Here are the contents of my presentation. Let's see how we do the QA and QC of medical imaging. Long time ago, at the time, we still using analog imaging product. If you want to perform QA or QC for medical imaging, you should do it manually and film by film, which would waste time and human resource. Nowadays, we can perform QA and QC from computer via PACS imaging viewing system. Just need to assign a radiological technologist to be responsible for it. Then he or she can design the way of QC according to the type of the modality, then perform. The overall operation will be smooth and much more easily. The quality inspection process consists of 3 steps, which are quality assurance, quality control, and continuous quality improvement, respectively. Here show the PACS workflow. First, we will require an examination via HIS. After perform the exam, we gain images on wrist and send images to PACS for storage. Finally, images will be pushed to EHR server. This is the workflow of Radiology department in Macau Public Hospital, which consists of 5 main parts. First, we need to select the type of the examination in the step of require, then do registration. The order will be sent from risk to modality work list. When we do operation start, before starting an exam, RT need to check the patient's personal information, then verify the modality protocol, and finally check both quality and quantity of images and send to PACS. We do QA and QC for these 6 modalities. The aim of QA is to find out which parts or details of the daily work of the radiology department that need to be monitored. These are the QA items for conventional radiology, normally included positioning, size of FOV, correct used marker, demonstration error, breadth sufficient, marker located correctly, image qualified, image quantity, and any artifact. The QA items for CT, which include positioning, isocenter, patient dose and image noise, IV contrast media concentration, image reformatted, and image quantity. QA items for MR are a little bit similar to those of CT, mainly focus on noise index, artifact, image reformatted, image quantity, For the QA of mammography, we mainly focus on positioning, correct used marker, demonstration error, image qualifies, image quantity, and artifacts. The image quality of FibroScan and DEXA is also our concern. Let's see how we make quality control of medical imaging. First, the procedure operates via PACS image viewing system instead of manual operated. We will check image by image, day by day, and it should be operated by a dedicated RT in the department. Proportionate spot check among daily checks from 6 main modalities. Besides, we should make a double check on medical images which have ever been corrected in the electronic health record. A statistic on the error rates of each QA item will be generated every 6 months. Here shows an example of the CR error rate statistics. The error rates of each QA item will be counted respectively. The slides show how we set up the proportional sampling for the quality control during the day's examinations. For example, we will make 100% images, QC for CR, mammography, FibroScan, and DEXA, and 30% images from CT, etc. The proportionate rate will be adjusted according to the result of the next error rate statistics. Next, let's see some practical examples and cases for quality control of medical imaging. Following are some practical examples for CR. The FOV are too large for cervical spine AP view. The shutter size are too large for the both ankle AP image and left shoulder AP view. Similarly, the shutter size being used were too large for chest PA X-ray. Non-standardized CR positioning examples. You can see on this image that an electronic marker was left on the bone. Obviously, both images are of poor quality. The electronic marker were put on unsuitable place on the images. Here shows some demonstration error images. Part of images from the protocol was strained. An example of breath insufficient on chest X-ray. Here are the improvement actions for above-mentioned practical examples, which included strengthened staff training, set up an online version of the positioning manual, which radiological technologists can consult and follow via the computer in the workplace at any time and require them to follow. Use entity marker. Send reminder messages via social media to remind staff to make correction. Check the effectiveness through regular race error rate statistics. Here is a CRQC case, which is chest X-ray PA and lateral view that taken from a Siemens Yashio digital X-ray machine. During QC, we found there are three problems on images. First, the CR was miscentering. The shutter size applied were too large. Then, after we tried to crop the image, the resulting image failed to obtain an ideal grayscale. The left two images are raw images of this case. On the right side image, it shown the grayscale could not be adjusted after it was cropped. The same situation did not occur on another digital X-ray machine of a different brand, Calcium DXR Evolution Plus. The evaluation of this case are, first, due to the large field of view, the original lung field became a chest and abdomen, so that in the process of cropping image reconstruction, an algorithm calculation error occurred due to the wrong adjustment of the inspection area by the machine. Second, the same situation did not occur in another digital X-ray machine, which shows that there are differences in the algorithm of different brands of digital X-ray machines. Improvement action of this case are to send reminder messages via social media to remind staff to make correction and to check the effectiveness through regular rate statistic. In addition, an electronic positioning box has been established in our department. It's been installed in the PC at every work location. If radiological technologists have any question regarding any patient positioning, they can open the book file to review and reference. Let's see a case of CTQC. This is chest and abdomen CT. We found a problem of inaccurate positioning of patient, which is miscentering of the isocenter during screening. Another problem found was there was an increasing in the radiation dose. You can see the condition of miscentering, and the MA was abnormally evaluated. The current CT has a built-in bow-tie filter, which is used to adjust the emitted fan-shaped X-ray. The energy intensity in the middle is the highest, and the outward divergence gradually becomes weaker. The goal is to have the strongest rays pass through the thinner parts of the body, and the weaker rays through the thinner parts of the body, so that the final rays arrive more evenly. If the patient is not in the center, the rays passing through the bow-tie filter cannot pass through the thickest parts of the patient correctly, which will affect the attenuation of the rays and increase the image noise. Result of improper bow-tie filter compensation commonly take the form of an increase in image noise and dose increase, Other negative effects of the patient mispositioning could degradation of spatial resolution away from the ISO center. Only way to improve the disadvantage of miscentering is technologists ensure the patient is in the center of gantry. A skull view will be performed to determine the scan range prior to the official scan. Computer will also calculate the patient body size based on skull view to determine the KV and MA we'll be using for the official scan. However, if scanning table is not in the middle of the CT gantry, the obtained skull view will be inaccurate. If scanning table is raised too high, the obtained patient size skull will be thinner than the actual situation, which will lead to high KV and MA during the official scan. Increasing the dose and noise. If scanning table is raised too low, the obtained patient size skull will be thinner than the actual situation, which will cause low KV and MA during the official scan, increasing the dose and noise. Different brands of CT machine have different calculation methods regarding to skull view. Some CT machines use the last skull view to calculate the KV and MA for the official scan, while some CT machines use both AP and lateral skull views to calculate the KV and MA for the official scan. So, if it is the CT machine that uses two skulls to calculate, after adjusting the height of scanning table, two skulls need to be performed again in order to calculate the correct KV and MA for the official scan. We will also check the contrast agent concentration to see if the arterial phase contrast agent concentration meets the diagnostic criteria. The following two pictures are both arterial phase, but they show obvious difference. The reference of RSNA 2016 and enhance of contrast agent concentration recommended guideline, and an enhancement of at least more than 250 HU of abdominal aorta was considered acceptable for the late arterial phase. In order to achieve the arterial phase criteria, the following aspects must be considered: puncture needle thickness, injection speed, contrast injection volume, patient size, patient condition, for example, heart failure. Use SmartPrep for monitor. Improvement action for this case are: increase staff training, send reminder messages via social media, and check effectiveness through a regular error rate statistic. The last QC case I want to share with you is from FibroScan. We found unqualified images when screening the images. After we found the error, the department held a review meeting, and there was a feedback from the staffs that due to job rotation, not every RT could be proficient in the operation of FibroScan. So we set up some action for improvement, included strengthened staff training. Dedicated radiological technologists are appointed for the work who may make a rotation every 3 months to maintain image quality and check the effectiveness through a regular error rate statistic. After share some QC cases to you, let me do the summary of how we do QC. It mainly consists of 5 steps, which are: first, to appoint a dedicated radiological technologist to be responsible for the QC position. Second, to design appropriate QC methods according to different modality. Third, to perform the QC and you may find problems. Then, to assess the problem and try to make solution for it. Finally, take action to promote further quality improvement. Continuous quality improvement, one of the most important concepts to understand with QCI is that all levels of people within the organization must be involved in the process of improvement, because QCI focuses not on just individual and their mistakes, but on the process. Each team member is more apt to participate in improving the organization. It is important that everyone participate, because if one spoke is not involved, the wheel will fall off and the quality cut can't be moving forward. Here is the conclusion of my presentation. Nowadays, quality assurance and quality control of medical imaging can be operating via the PACS system instead of manual operated. Understanding which part of the daily work of the radiology department that need to be monitored is the key point of quality assurance. Based on the precise QA items, daily routine image quality control is carried out by dedicated RTs, and effectiveness is monitored through regular error rate statistic, thus effectively promotes the continuous improvement of image quality by all staffs. The sampling rates of each modality will be adjusted according to the error rate statistic. This is the reference. Thank you for your attention.
Okay, thank you, Ms. Anna Yang Peng, for this informative talk. I think she mentioned a lot of things that we may overlook in our daily work, because most of the time we are working with the patients that somehow we will forget what is going on behind on our daily work. So I think this reminds us a lot about how important is the quality control part in our work. So the Q&A question will be next after we finish all the lectures. So now let's welcome our second speaker. The second speaker is Ms. Jerry Lai Kai Hong. He's the former chairman of MRTA, and now he is the supervisor of our MRTA. Today, his topic is the role of frontline radiological technologists in diagnosing and managing kidney disease in Macau Government Hospital. Let's welcome Mr. Jerry Lai Kai Hong.
Hello everyone, how are you? Happy New Year. My name is Jerry. I'm from Macau. I'm a radiological technologist working for the Macau Government Hospital. I have working experience of more than 16 years in the field of radiography. I'm also a supervisor of the Macau Radiological Technologists Association, the MRTA. It's my pleasure here today to give a presentation at the 33rd Asia CPD program, which is also the 34th CPD program of the MRTA. My topic for tonight's CPD is the roles of frontline radiological technologists in diagnosing and managing kidney diseases in the Macau Government Hospital. Through my presentation, I focus on sharing some frontline experiences from where I work regarding kidney diseases. Well, before we move on, first let's look at the prevalence and impact of kidney diseases in Macau. Macau is a small city with a population of about 650,000 people living in an area of just 33 kilometers square. As you may not know, Macau is the most densely populated region in the world. As shown on the table on the right, Macau's elderly population grows by approximately 15% every decade from now on. The prevalence of kidney diseases in Macau has been on the rise, attributed to factors such as an aging population, changes in lifestyle, and an increasing prevalence of chronic conditions such as diabetes and hypertension. Therefore, kidney diseases have emerged as a significant health concern in Macau, exerting a remarkable impact on public health. These diseases not only pose a burden on affected individuals, but also place a strain on healthcare resources and infrastructure. The impact of kidney diseases in Macau includes a higher risk of renal failure, reduced quality of life, increased healthcare costs, and the need for dialysis and kidney transplantation. Therefore, it's important to note that kidney diseases can vary in severity, ranging from mild and manageable conditions to chronic and potentially life-threatening illnesses. Hence, early detection, proper diagnosis, and timely treatment are essential in managing kidney diseases and preserving kidney function. So, what are kidneys? Kidneys are vital organs located in the upper abdominal area on either side of our spine. Their primary function is to filter waste products from our blood, regulate fluid balance, and maintain proper electrolyte levels in our body. Kidneys also play a role in blood pressure regulation and the production of certain hormones. Each kidney contains millions of tiny filtering units called nephrons, which help in filtration and purification process. And what are kidney diseases? Kidney diseases refer to a range of conditions that affect the structure and function of the kidneys. These diseases can impact the kidney abilities to filter waste products and excess fluids from blood, regulate electrolyte balance, produce hormones essential for body functions. After we know what kidney disease is, now let's look at some common types of kidney diseases. Some common types of kidney diseases include chronic kidney disease, CKD, which is a progressive condition characterized by the gradual loss of kidney function over time. CKD may be caused by conditions such as diabetes, high blood pressure, autoimmune disorders, and genetic factors. Acute kidney injury, AKI, which is sudden and temporary loss of kidney function, often caused by conditions such as dehydration, severe infection, medication toxicity, or obstruction of the urinary tract. Kidney stones are some hard deposits of minerals and salts that form in the kidneys and can cause severe pain when they pass through the urinary tract. The size and location of kidney stones can vary. Polycystic kidney disease, PKD, which is a genetic disorder characterized by the growth of numerous cysts in the kidneys, leading to kidney enlargement, reduced function, and potential complications. Kidney cancer, which is the development of malignant tumor in the kidneys, with renal cell carcinoma being the most common type. Risk factors include smoking, obesity, and certain genetic conditions. Renal artery stenosis, which is narrowing of the artery that supply blood to the kidneys, often due to atherosclerosis. This condition can lead to reduced blood flow to the kidneys and subsequent hypertension. As many radiological exam and procedure involve the use of contrast media, they may have some impacts to the kidneys, causing contrast-associated acute kidney injury, or what we call CAAKI. CAAKI, also known as contrast-induced nephropathy, CIN, which refers to a temporary decline in kidney functions that occurs within 48 hours after the administration of iodine contrast media. CAAKI typically manifest an increase in serum creatinine levels, indicating impaired kidney function. According to ACR manual on contrast media, the exact mechanism underlying CAAKI are not fully understood. CAAKI may occur regardless of whether the contrast media was the cause of deterioration. It is important to note that CAAKI is generally a temporary condition, and kidney function often returns to normal within a few days or weeks. In order to minimize the risk of CAAKI, healthcare providers should take precautions such as the baseline serum creatinine determination. In other words, to do blood tests to assess the patient's kidney function before the exam. Then use the serum creatinine level to calculate the eGFR, which is the glomerular filtration rate. According to ACR manual, they recommend no contrast shall be given if eGFR is below 30. However, in Macau, our standard is a little bit higher, as we won't give contrast if the patient's eGFR is below 40. Another precaution is IV hydration. In Macau, typical preparation for hydration is dripping 500 ml normal saline at 100 ml per hour for 6 to 12 hours before contrast, and continue 3 to 12 hours after the exam. In some severe cases, as shown in this picture, this patient has got an eGFR of only 14. After considering the risk-benefit analysis to the patient, the radiologist requests a Peng CT scan instead of a contrast one. In Macau, we usually refer to the ACR manual that if a patient has the following risk factors, that he or she will be asked to do a blood test before any exam involving the use of contrast media. These risk factors include long chronic kidney disease, CKD, remote history of AKI, dialysis, kidney surgery, kidney ablation, albuminuria, history of diabetes, and metformin using. So how do we treat contrast-associated acute kidney injury in Macau? The treatment of this in Macau, as in any other location, generally focuses on supportive measures to manage and monitor kidney function, while allowing the kidneys to recover. Here are some common approaches to treat CAAKI. Hydration. Adequate hydration is crucial to help flush out the contrast agent and maintain kidney function. Discontinuation of nephrotoxic medications, such as non-steroid anti-inflammation drugs. Monitoring kidney function. Regular monitoring of kidney function through blood tests, which includes the serum creatinine levels and estimate eGFR in order to track the progress of renal recovery. Renal replacement therapy. In some severe cases of CAAKI, where kidney function is highly impaired, renal replacement therapy, such as hemodialysis or continuous renal replacement therapy, or what we call CWRT, may be required to temporarily assist in filtering waste products from blood until the kidney function improves. Alright, we've just talked about some common types of kidney diseases, contrast-associated acute kidney injury, CAAKI, some precautions and treatment of CAAKI. So now let's move on to some common diagnostic imaging modalities for kidney diseases in Macau. The first one is conventional radiography, commonly known as X-ray. X-ray has been a fundamental imaging modality in the medical field for many years. Many thanks to our X-ray father, Röntgen, who discovered X-ray, and so we have our profession. Nowadays, though CR is not the primary imaging technique for evaluating kidney diseases, it still holds its value in certain situations. In Macau, CR is very likely to be used as an initial screening tool to detect kidney stones, such as the KUB X-ray. Intravenous pinogram, IVP, also known as intravenous urogram, IVU, may also be used to evaluate the urinary system, particularly the kidney, ureters, and bladder. By using contrast, IVP can provide information about the flow of urine and the overall function of the kidneys. However, with the advancements in imaging technology, IVP has become less common in Macau. Other imaging techniques like CT is often preferred because of its high resolution and ability to provide more detailed information. Another modality is ultrasound. Ultrasound imaging is widely used in the evaluation of kidney diseases due to its accessibility, safety, and real-time imaging capacities. In Macau, ultrasound is often the initial imaging modality for assessing kidney conditions. Ultrasound provides information about kidney size, shape, the presence of stones, mass, cysts, or obstructions. Ultrasound-guided biopsy of the kidneys can also be performed to obtain tissue samples for pathological analysis. Furthermore, ultrasound can be used to guide procedures such as percutaneous nephrostomy, which involves the insertion of a tube into the kidney to drain urine away in cases of urinary obstruction. While ultrasound is widely used valuable imaging modality for kidney scans, it does have some limitations, such as limited visualization. Ultrasound may have difficulty visualizing certain structures within the kidneys due to factors such as obesity, bowel gas, or patient anatomy. This can make it challenging to assess specific details or detect small abnormalities. Operator dependency. The quality of ultrasound image can vary depending on the skill and experience of the operator. Obtaining optimal image may require a skillful sonographer or radiologist who can accurately interpret the results. Inability to provide detailed tissue categorization. While ultrasound can identify the presence of a mass or abnormalities within the kidney, it cannot definitely determine the nature of the lesion. Further imaging modalities such as CT may be necessary for detailed tissue categorization. In Macau, CT scans have become an essential tool in the diagnosis and the evaluation of kidney diseases. CT scans are particularly valuable in identifying kidney stones, tumor, cysts, and all other structural abnormalities related to kidneys. CT provides detailed cross-sectional images with three-planar imaging reconstructions, axial, coronal, sagittal views of the kidneys, which enable radiologists to detect and characterize various conditions. This picture shows CT scan of a typical renal cell carcinoma. Picture A is the Peng scan. Picture B is the 25 seconds post-contrast arterial phase scan. C is the 60 seconds venous phase scan. Typical renal cell carcinoma on CT scan shows fast wash-in of contrast media during the arterial phase and fast wash-out during the venous phase. With the availability of advanced CT technology, it has significantly enhanced the accuracy and efficiency of kidney disease diagnosis. Plus the use of contrast media, CT angiography, CTA, can assess the blood flow to the kidneys, helping in diagnosis of conditions such as renal artery stenosis. These CTA scans shows a right renal arterial aneurysm during the arterial phase. This is the same patient We can also do a volume rendering reconstruction to look at the right renal artery aneurysm three-dimensionally. Whenever the kidneys are mentioned, there's a pair of organs that's often been overlooked. They are the adrenal glands. Adrenal glands are small, triangular-shaped endocrine glands located on top on each kidney. Despite their small size, these glands played a vital role in regulating various physiological processes through the production of hormones. Their functions are essential for maintaining homeostasis, which is the balance inside our body, responding to stress, and controlling metabolism. Adrenal lesions are very common. Many of these lesions are incidentally discovered, usually more than 1 centimeter in size, and we call it incidentalomas. Because of the fast scanning speed of CT and more other pathological information can be given, adrenal CT, in order to see the adrenal washout time, is always the main tool to diagnose whether the adrenal lesion is benign, or commonly known as adenoma, or malignant. In other words, cancer or carcinoma. As we know that the Hounsfield unit of fat or lipid usually tend to have a negative value. Other than cyst or myelolipoma, lipid-rich and lipid-poor adenoma are the two most commonly found benign adrenal lesions from CT. Lipid-rich usually tend to have a Hounsfield unit of less than 10 on non-contrast CT scan, while lipid-poor adenoma that gives a Hounsfield unit of more than 10. This is an example showing lipid-rich adenoma, which gives a measurement of -5 Hounsfield unit on non-contrast CT scan. And most of the adenoma found on CT tends to be lipid-rich adenoma. In terms of lipid-poor adenoma, this image shows an indeterminate adrenal lesion on the non-contrast CT scan. On non-contrast CT scan, it measures 24 Hounsfield unit, which is higher than 10 Hounsfield unit. That gives an indication of non-lipid-rich adenoma. So, in order to tell the lesion is benign, which is lipid-poor adenoma or malignant carcinoma, iodine contrast will be given to look for the 60 seconds venous phase. As shown on the right side of the picture, the 60 seconds venous phase gives a measurement of 88 Hounsfield unit, which gives an information that it is not very enhanced and the contrast is not staying and has been washed out quickly. So we can generally tell that it is a fast washout behavior, and very likely it will represent a lipid-poor adenoma. Well, to sum up what I said before, in order to quickly differentiate whether the adrenal lesion is benign or malignant, we shall give contrast to look for the 60 seconds venous phase. In terms of lipid-rich and lipid-poor adenoma, contrast will be washed out quickly at the 60 seconds phase. However, for adrenal carcinoma, contrast usually tend to stay and won't be washed out rapidly at the 60 seconds phase. Sometimes, a 15 minutes delay CT scan will be prescribed by the radiologist to calculate the absolute washout and relative washout value in order to diagnose adrenal adenoma. Let's move on to the C-arm fluoroscopy. In Macau, C-arm fluoroscopy for urologists is a specialized imaging technique used in operating theater. It involves the use of a C-arm to provide real-time imaging during urology procedures. We use a C-arm to guide the urologist to provide continuous visualization of the urinary system. With the help of contrast, it also provides dynamic imaging ability, allowing the assessment of renal structure and anatomy, and the monitoring of the procedure in real time. Common urology procedures by using C-arm in the operating theater include percutaneous nephrolephthalmy, or what we call PCNL. PCNL is a minimally invasive procedure used to remove relatively large kidney stones. C-arm enables the surgeon to visualize the placement of the shafts, guide the insertion of instrument, and monitoring kidney stones fragment during the procedure. Another very common C-arm guide procedure is URSL, which is ureteroscopy lithotripsy with laser. URSL is also minimally invasive surgical procedure used for treatment of relatively small kidney stones compared with PCNL. This is a request form from the urology department to us to ask for the assistance of C-arm guidance during their procedure. Pictures on the left shows the C-arm system in my hospital. Picture on the right shows the CT scan review on monitor inside the operating theater before the URSL procedure. As you can see, the surgeon is going to deal with the left renal stone, which was found on CT. During the C-arm guide URSL procedure, the patient is placed under anesthesia and a ureteroscope is inserted through the urethra, bladder, and into the ureter. The ureteroscope allows the surgeon to visualize the stone and the surrounding structures, and the C-arm provides dynamic imaging of the urinary tract, allows surgeon to monitor the progress of the procedure and guide the positioning of the instruments. C-arm also provides visualization of the stones, their location, and anatomy of the urinary system. These real-time imaging techniques help the surgeon to precisely target and fragment the stones using laser energy. The surgeon may use additional instruments such as baskets to remove the stone fragments or allow them laterally pass through the urinary tract. In Macau, C-arm fluoroscopy guide URSL procedure has become a standard approach for the treatment of kidney stones. It combines the benefit of real-time imaging with precision of laser, resulting in improved outcomes, reduced procedure time, and improved patient safety. Now let's move on to the last techniques regarding the kidney disease. The interventional radiology technique, IR. In recent years, IR has revolutionized the diagnosis and treatment of kidney disease. IR also refers to minimally invasive procedures performed by the radiologist under fluoroscopy and acquisition mode. There's no doubt that IR techniques has significantly transformed the field of medicine, offering alternatives to traditional surgical approaches for the management of kidney diseases. Here are two types of IR procedure examples. The first example is renal artery embolization. This IR procedure is used to treat certain renal conditions such as renal tumors, arteriovenous malformations, AVM, or uncontrollable bleeding. During this procedure, a catheter or a guiding catheter is guided into the renal artery, and small particles, gel form, or coils are introduced into the renal artery, blocking the blood supply to the target area. This helps to shrink tumors, close off abnormal blood vessels, or control bleeding. As shown in the picture, picture A shows bleeding from one of the renal arteries, and picture B shows embolization of the bleeding artery by using some gel form particles. Another common IR procedure is renal artery stenting. As shown in the picture, that the right renal artery stenosis was found on CT. As you can see, the right kidney is not very enhanced after the contrast. Therefore, a request for IR procedure is prescribed to help treating this stenosis. This is the same patient. During the IR procedure, a guiding catheter is introduced successfully through guide wire from the right femoral artery into the right renal artery. Contrast is then injected to see the real-time condition of the narrowing of the renal artery. After we did some measurements at the stenotic area, a balloon mount stent was then inserted and opened. Proper blood flow of the right renal artery was restored through the final run. It is important to note that the use of C-arm and IR procedures involve radiation exposure to our staff members, such as catering. So, in order to minimize radiation exposure, the duration and exposure dose shall be kept as low as reasonably as achievable. Moreover, lead shielding such as lead gown, lead goggles, and thyroid shield are used to protect our technologists, surgical team, and staff members from unnecessary radiation exposure. To sum up my presentation, kidneys are vital organs responsible for filtering waste products from blood and maintaining fluid balance in our body. Kidney diseases include a wide range of conditions that can impair the normal functioning of the kidneys. Through imaging modalities such as X-ray, CT, ultrasound, C-arm fluoroscopy, and interventional radiology, healthcare professionals can easily detect, diagnose, and treat kidney disease. Last but not least, it's very important for radiological technologists to collaborate closely with radiologists, urologists, and other medical healthcare professionals, adopting a multidisciplinary approach to kidney disease management. That's all of my presentation. Thank you for your time. Thank you.
Thank you, Mr. Jerry Lai Hong, for such an informative talk. Now let's move on to our Q&A section. Is there any question from our panelists? Okay. Any question?
Yes.
Okay, yes, Mr. Lob.
Yes. Hello. Thank you. Thank you, MRTA. Okay, I have a question for Mr. Chen Peng first. Okay, in quality assurance and quality control, your society do on in quality control and quality assurance. Your society do everything. First question. The second question, I saw you say only and quality control and for in public hospital. How about in private hospital?
Maybe I help Ms. Yeung to answer this question because due to the web problem, maybe she cannot online this time. So the first question is that this topic is only mentioned about the condition about the quality assurance and quality control of the medical imaging in the public hospital only. So we only only show you how the condition about this topic around the public hospital, and not by MRTA. This is only due by the colleagues that work in the public hospital, not by our society.
Do you understand, Locke? So
yes,
because the speakers is work in my department, Anna is working in my department. She's not the society. So I also want to discuss about the quality control in the other country. I want to know. So we have Malaysia, Sabah, have Taiwan, have Singapore, have India. Can you share about your hospital? How you do the QC in your daily, or you will do that or not? Sabah, in Malaysia, it is a routine to do that or not every day?
Okay. As far in Malaysia, I understand that most of the hospital not doing it daily. It's not a daily procedure for the QA.
So there's an audit. You do the audit every 3 months, or what? How you control the quality in the hospital? And then
the quality control is sometimes done 6 monthly, or other private mostly is they're doing it. The audit is done only yearly. Yearly.
Okay.
That is compulsory, but that is rules by the government. That is yearly. They need to submit the report. But individual hospital, most of them is depending on the their performance as well. Some they have what quarterly. Some is 6 monthly, half yearly, and the rules, the regulation by the government is yearly.
Okay. So and how about
I think in Malaysia, every hospital need to do the reject analysis every day or weekly. So they have a routines because the government actually have a schedule for different kind of QA. So, but for image qualities, they need to do the reject analysis. They have standard forms published by the government. Actually, what our president say is very right. Government take care of all the hospital.
No, currently the government ruling is monthly. That is monthly report. But the QA system for the reporting, for the licensing is yearly. But routinely they do it monthly for the reject analysis.
Yes. Okay. So you have to do that, but not same as you have a special radiographer to do that every day. She will check all the imaging, all. So in Vietnam, how about Vietnam, Locke?
We have in quality control most for in private hospital. Now we are society have for in government build the quality control law for every on the hospital.
Okay. And Meng, how about Hong Kong?
The QA is always routinely is checked by the physicists in Hong Kong. Yeah.
So check by physicists, just a check by the dose. So not a
yeah.
And you because you are using a PAC system, right? You have 1,000 patients per day. Okay.
Yeah.
You can do how you can know how about the image to send to the PAC to share others. It is okay or not? Wrong name. They have these ways.
Okay. Because we have a QA system for the image. One radiographer check check the name in the image first, okay, in the panel, check the image, and then the second radiographer is a QA, have a QA on the before sending to the PACS, okay. After, before sending to the PACS, they have another one to check it. Yeah. So and the name is we get the patient data parameter is from the another system. It's called RIS system in Hong Kong. So another counter check is the RIS system, and the we use this they can if they match the system is automatically match to check the patient data. Yeah. So
yes,
the QA is from the people and from the system. It's so security in Hong Kong.
Yes, yes, sure. So you have a quality control to each patient before to send to the PACS, right?
Yeah.
Because you have two radio offers, right? But the part just only one radio offers for take care of one machine. So not so different.
Oh.
You know?
Okay.
If you are lucky,
because
you have a man. You
yeah.
You never have a lot. But in Macau, in my hospital, just only one radio offer in the MRI, maybe sometime one radio offer in the CT. So they are very, very hard. So we have one position for the radiographer to check the all. You know, if you in Hong Kong, you have two radiographers per room or per machine. It is okay because you also to check everything before you send the PACS. So you also the QC for the each exam. Right.
Okay. Hong Kong standard is
one.
Yeah.
Yes.
Hong Kong standard is one machine two radiographer to operate. Yeah.
Okay. My hospital also sometimes have, sometimes not have. So not enough. And how about Singapore, Denise? In your department?
Yeah, so I think because QA and QC involves a lot of different types of checks, right? So it's quite varied. Like we don't have a fixed schedule. For example, like if I talk about my section first, like ultrasound, we have two types of QC. We have a weekly QC where we will check the probe quality and degradation, every week. But we also have a 6-monthly QC where we will check like more thoroughly with the phantoms to make sure that the system is still measuring everything accurately, similar to what the engineers do whenever they come to do preventative maintenance. Yeah, so that's for ultrasound. Like for memo, I know they have like a daily QC, right? Because it's very important that the images that are obtained must be accurate, right? Especially for memo when they're looking at microcals and all these very, very small, fine things. Same for like BMD, right? It had to be like a daily calibration and QC check. I think CT also. But of course, it varies between the modalities. For general X-ray, we have our physicists who will come and do like the QC checks, to look at the radiation dose, right? And also doing all the specific tests for the contrast signal ratio, all those things. Then daily, if you're talking about like the rejects and QC at the system itself, right? Checking the images before sending to PACS. That one is done, of course, with every examination, right? Every radiographer has to make sure that all of the patient details is correct. The whatever is requested corresponds to the request. And for reject rate analysis at each system, we have a monthly check in my hospital. So there's a team that will go around taking reject rates from all of the various CR and DR systems to calculate the reject rates for each radiographer. And then we also have the image quality team, which will look at image quality, I think bi-monthly, because we need to generate a certain enough data for us to analyze and audit. Yeah, so lots of different aspects of quality management in a radiology department. Yeah.
Yes, so yes, right.
SSR is actually going to publish our newsletter soon, and this month, actually this issue, we have a special feature on QA and QC. Yeah, so do look out for that, and then you can learn more about you know, the various practices in the other hospitals in Singapore as well.
Okay. Thank you, Dennis.
Thank you.
And how about Taiwan? So,
Oh, can you hear me?
yes.
Can you hear me? Okay. In Taiwan, we have a law for we have a draw up the law for QA. In Taiwan, we have a to need to do QA. The machine was about mammography, CT, and fluoroscopy. But we still not draw up the QA procedure for the conventional radiography. But our program was follow the ACR and the AAPN. That's all.
Okay, thank you, Tan. Hello, Mr. Sukianto. Hello, about Indonesia. Before this, I give you a congratulations, Sukianto. Oh, this is some. Oh, hello, Sukianto.
Hello. Yeah.
Hello, congratulations, President again.
Oh yeah.
And how about in
Yeah,
your hospital there in the Indonesia? About the QC, daily QC you have, or monthly, or how to do that?
Yeah, in Indonesia, we make a collaboration with medical physicists when doing QA and QC, Fernando.
Okay.
Usually, radiographer do every daily, but for monthly, 3 monthly, usually for medical physicists. Yeah. And also the main role is for medical physicists to make quality assurance or quality control, especially for X-ray exposure, the radiation dose is medical physicists. But for recheck analysis, for daily check, or radiography, or in CT or MRI, they'll be done by a radiographer. You see.
Sure. Oh, I think it's all same. Right.
Yeah.
And how about India, Kumar? Hello, Mr. Kumar.
Very good evening. Happy New Year to all. It's a very interesting session today. It's a really enjoyed that with lot of pictures and other things. Happy to see that. And in India, in most of the centers, we are doing the regular QA QC programs in all the equipments. Usually, the radiation safety officer take care of the equipments in all the radiology services, and periodically every month and quarterly and annual checkups are done as per the government directives. Here in India, AERB, Atomic Energy Regulatory Board, we have to submit a report to get our licenses back for the equipment continuation. So every year, all these processes are regularly continued in most of the centers. Only a few centers might be missed, but the ARB is very keen on making the QA QC programs for all the radiology services nowadays. So in India, these are mandatory now. They are regularly doing, and it is up to the very high quality they are maintaining.
Yes, okay. Thank you, Mr. Kumar.
Thank
okay,
you,
Edwin, back to you, moderator, to continue. Edwin, your mic.
Okay, yes. Okay, thank you for the discussion about all the QA questions. So I also have a question from Mr. Jerry Lai-Kai-Hong. So I want to ask, how does the X-ray imaging contribute to the initial screening of the kidney disease in Macau? And what are its limitations in terms of the sensitivity and the specificity? Mr. Jerry? Hello?
Hello.
Yeah.
Yes. For X-ray, as I mentioned before, in terms of initial screening of kidney diseases, X-ray can usually detect the presence of kidney stones in the urinary tract, and also for X-ray, if we use contrast, we can also see something like the obstruction of our urinary system. And for limitations, X-ray may be like limited to detect like soft tissue, and also have some limitation for small stones that are, because some small stones maybe they are not radiopaque to X-ray, so we cannot see it. And also for X-ray, we involve in the use of some X-ray exposure dose. Just in case of repeat X-ray, this may increase the dose of the patient. So so that's all for the question, I think. Thank you.
Yes, thank you, Mr. Jerry. Any other question? So
I feel sorry.
Yes,
I feel
okay,
the
Mr. Locke.
Jerry, I feel a kidney. For example, in my country now, I think that everybody forgot in Israel for kidney. It's like IVU. The first we use the ultrasound, and the second CT contrast loader like wash out like you told. I remember 5 years ago, everybody we forgot. I don't know how another country. We don't use IVU in Israel. We don't use it now.
Yes, in Macau, we also we don't often do the IVU. We don't always do IVP also. Yeah, but if you want to see the outline of the urinary system with the contrast, you can actually see like some obstruction and some structure of the ureters, something like that. But mostly we will perform a CT scan to see the kidney pathology instead of IVU, I think. Yes.
Yes, it's the contract with low dose. We have many information, many profits for patients.
Yeah,
Thank you.
we can use low dose also. Yes, you are correct. Yes.
Thank you.
Yes, okay, thank you, Mr. Locke and Mr. Jerry. So there's no question. I think it's the end of the Q&A session. Now let us hand the time back to Ms. Pichiluna to announce the others information. Ms. Pichiluna. Ms. Luna, hello. Oops, maybe
Pichi is
maybe Pichi Luna is not available at this moment.
Hello,
So,
Pichi.
Hello.
Okay. Pichi on microphone. Pichi.
Pichi.
Your microphone is off. Hello.
Maybe microphone now.
So the following program is the next CPD will be hosted by Cambodia. Sophie, are you ready? Sophie also.
Yes. Do you hear me?
Yes, Sophie.
Yes.
Okay. Okay, thank you so much for our president and speaker today. And so I would like to say sorry for too late join today meeting due to I have another meeting in the hospital. So first, thank you for inviting Cambodia as a CPD member. So on behalf of the Cambodia Association, I would like to announce the next CPD for the next month will be hosted by Cambodia. So we will conduct the meeting on the Sunday, 25 February 2024 at 3 p.m. So the meeting will be hybrid. So it means that Cambodia will have the meeting the same with the CPD. So after the host of CPD, our Cambodia Association will have the next meeting. So I just inform for the all president and all moderator here. Yes, thank you so much. So for about the poster, I will share to the group later. It's okay, right? All president.
It's okay. We have Marco to help the Cambodia how to do that.
Yes,
Thank you to
yes,
okay to support
yes.
our platform. So get back to the Pichi.
Okay.
Yes, so thank you to our moderator, Edwin Al. We also would like to say thank you to all our presidents who are here and our panelists. The MRTA has just provided us with two great speakers who have just presented valuable topics and interesting discussions. We hope that we have more of quality assurance and quality control, and also hear more about the advancing roles of radiologic technologists in different fields of practice in radiologic technology. Again, thank you, Miss Yeong Cheng Peng and Mr. Jerry Lei Kai Hong. We have learned so much from your very interesting and important discussions, and we hope to hear from you again next time. But in the interest of time, we have to end here. We have just heard the invitation of the Cambodian Association of Radiological Technologists President Sophie Lee. So we shall be marking our calendar, and we shall be joining us in the next CPD Asia next month. We give thanks to the support of our MRTA sponsors and VT Healthcare Vietnam. Also, we are grateful to our two great speakers. And most of all, we are sincerely thankful to the host society, the Macau Radiological Technologists Association, to President Fernando Koch, to all your officers, and to our moderator, Edwin Au, and the amazing MRTA CPD Organizing Committee. Also, we would like to say thank you to the support of the member societies presidents, to our very hardworking CPD Asia IT team, and to all the registered participants who have made this online CPD Asia, the first in 2024, a very successful program. We shall see each other again next month in the February CPD Asia. Again, I am Pichi Luna, and I say thank you, everyone, and have a great day.
Okay, thank you.
Thank you so
Goodbye.
much.
See you all the next
See
month.
you.
Thank you very much.
Bye.
Thank you. Bye
Thank
bye.
you. Thank you,
Bye-bye.
everybody. Thank you.
Thank you.
Thank you
Bye-bye.
all for a wonderful session.
Yeah, thank you
Thank you,
all.
President Sugianto.
Thank you.
Yeah,
Congratulations.
Selva. Yeah,
Yes. Have a nice
Happy
day, all
CPD Day.
president.
yeah.
Thank you. Thank you all.
Thank you, everyone. Thank you.
Recording stopped.
Ya, demikian tadi CPD Asia ke-33, Bapak Ibu, semoga bisa dinikmati dan memperoleh manfaat dari CPD Asia ke-33 tersebut. Ini temanya QC/QA ya. Demikian Mbak Puspa, Mbak Pamela mungkin bisa menghidupkan kamera begitu. Oke, mantap. Silakan mungkin bisa closing. Pamela, atau ada yang ingin disampaikan, silakan. Terima kasih sudah setia di CPD Asia ke-33, Mbak Pamela. Silakan.
Iya, selamat malam semuanya. Terima kasih sudah ikut bergabung tadi ya, menyaksikan CPD Asia yang ke-33. Dan saya rasa cukup interaktif sekali ya, dan menantang. Materinya juga sangat menarik. Semoga teman-teman yang lain yang hadir di sini juga dapat menikmati acaranya tadi dan mengambil ilmunya tentunya ya, Beli Putu ya.
Iya, betul sekali. Dan itu pertama kalinya Macau itu nanya ke semuanya bagaimana QC, QA di tempat kalian masing-masing, di masing-masing negara. Itu pertama kalinya jadi interaktif seperti itu. Biasanya nggak, biasanya ya biasanya mereka nanya ke narasumber, ini tumben gantian mereka sebagai host itu nanya ke masing-masing negara peserta gitu.
Dan
Dari saya sih
iya,
jawabannya
bagaimana?
ya ada harian, ada ya Malaysia bilang pemerintahnya ngatur dan lain sebagainya. Gitu ya.
Iya, dan pastinya informasi antar negara tadi sangat bermanfaat ya untuk kita ya, karena ternyata nggak cuma di negara kita aja yang begini, ternyata tempat lain juga begitu, dan pastinya dari interaksi tadi kita bisa mengambil mana hal yang positif tentunya untuk kita tiru, dan mungkin agak menyingkirkan yang kira-kira kurang bermanfaat. Dan untuk teman-teman semua di sini, pesertanya hari ini ada, lumayan ramai juga ya. Mudah-mudahan untuk CPD selanjutnya bisa lebih ramai lagi ya Beli Putu ya.
Iya, betul. Kemudian satu lagi yang di luar kebiasaan CPD nih, di endingnya itu biasanya diumumkan, oh tadi sudah ya, kayaknya Kamboja sebagai host selanjutnya, Bu Irma ya. Tadi yang terakhir tuh dari Kamboja itu apa yang disampaikan ya? Saya nggak jelas tadi itu. Sepertinya beliau yang jadi host CPD Asia.
Ya untuk Februari sepertinya ya, Bu.
Iya betul. So pilih, betul. So pilih.
Oke. Kemudian untuk acara selanjutnya nanti dari Pari akan menginformasikan apakah begitu Beli Putu untuk seluruh teman-teman radiografer di Indonesia?
Iya. Untuk CPD Asia memang terselenggara tiap bulan. Kemudian seperti CPD sebelumnya, teman-teman harus register, harus mengisi pretest, posttest, kemudian waktunya ya minimal 75% dari waktu kehadiran itu baru dapat sertifikat. Itu di kontraknya seperti itu ya.
Ya, sebenarnya dengan jumlah radiografer di seluruh Indonesia yang ribuan dan hadir di acara kali ini hanya 29 orang, kok ngelihatnya sayang ya, karena ilmunya benar-benar bermanfaat sekali itu tadi dan jarang, karena kita bisa sekaligus studi banding gitu. Gimana ini ya rencananya ya? Apakah selanjutnya nanti kita akan blast lebih meriah lagi supaya banyak yang mengikuti atau batasan maksimal berapa sih Beli Putu untuk pesertanya? Untuk next event kira-kira?
Sebetulnya kita pakai Zoom 500, Mbak. Jadi
Wow,
sampai
harusnya bisa
maksimum 500 bisa.
dimanfaatkan ya.
Ya,
Ya.
kalau dari sekarang sih karena memang mungkin yang pertama SKP-nya nggak ada mungkin. Itu yang paling utama. Kemudian ya eh, mungkin temanya juga di luar dari eh, apa namanya ya yang dinikmati teman-teman di luar dari eh, hobi atau fokus mereka begitu. Mungkin topiknya begitu juga. Yang ketiga mungkin karena bahasa Inggris dan kemudian bahasa Inggrisnya bahasa Inggris Asia Tenggara ya. Jadi bahasa Inggris dari Macau kadang-kadang beberapa kata juga ada yang sulit kita tangkap gitu.
Dari logatnya juga mungkin ya Beli ya.
Betul, betul.
Iya.
Tapi 29 ini udah termasuk banyak ini. Eh kapan?
Oh iya, saya mau nanya ini untuk seluruh peserta dari 29 peserta ini apakah tadi ketika ngisi apa ya link kan ditanya tuh pas kita ngisi post-test apakah untuk ada saran untuk acara selanjutnya materinya gitu, materinya atau ada saran mengenai narasumbernya gitu, mungkin ada yang bisa kasih saran di sini atau karena 29 akan kita tanya satu-satu, bagaimana Bapak dan Ibu sekalian? Dari Pak Fahrudin mungkin.
Ya,
Boleh
ini bagus
saya
juga.
menyapa? Assalamualaikum Bapak Fahrudin. Assalamualaikum Bapak
Sebentar, saya
Fahrudin.
belum bebaskan unmute-nya.
Oh, oke.
Sekarang ya silakan bisa unmute semuanya.
Waalaikumsalam Bu.
Iya, Pak Fahrudin, gimana ini? Dari Kaltim ya, dari mana?
Ya Kaltim Bu, Kaltim.
Iya. Boleh ditanya, boleh saya tanya mengenai pesan dan
Kesannya sih ya mungkin setuju sekali sama Mas Putu mungkin terkait bahasa mungkin yang agak dipahami mungkin. Soalnya agak beda karena bukan bahasa Inggris asli gitu kan.
iya. Tapi jangan kecil hati, Mas. Saya juga tadi dari beberapa materi banyak yang agak kurang bisa diterima. Jadi saya tadi sambil nyanding dengan Google Translate apa berapa kalimat yang ngerti langsung diketik aja. Tenang, itu bukan kendala Mas Fahrudin aja. Kami juga merasakan kok. Oke, tapi dari 100% materi yang disampaikan tercapai lah ya inti-intinya.
Iya, tercapai soalnya kan ada slide juga yang bisa kita perhatikan gitu.
Oke, baik. Ada saran nggak ini untuk selanjutnya? Apakah mungkin dari negara lain yang diharapkan ada materi apa? Atau mungkin dari kita sendiri nanti akan menyampaikan?
Ya bisa juga kalau bisa Indonesia lagi yang menjadi tuan rumah gitu. Lebih mudah nih.
Amin, mudah-mudahan bisa segera direalisasikan ya. Jadi Indonesia jadi tuan rumah CPD Asia ya.
Bulan
Baik.
Juli, Mbak Puspa, kita akan jadi host CPD Asia.
Oh, tuh bocoran
Ya,
dari
mungkin
Mbak
dari
Irma
Bapak
bulan
Ibu
Juli.
ada masukan tema atau ada yang ingin menjadi pembicara kita, mungkin nanti bulan Juli.
Iya, Pak Fahrudin, tadi kan kita sudah tersambung tanggung nih ngobrolnya. Kalau Pak Fahrudin sendiri punya ide apa ini untuk materi yang mau disampaikan kira-kira?
Apa yang mungkin terkaitan aja mungkin ya CT scan yang terkait yang lagi dibahas COVID yang ke atas itu ya apa istilahnya itu yang baru ya. Mungkin bisa soalnya banyak teman-teman juga yang nanya terkait diagnosanya seperti apa, apakah sama dengan COVID-19 atau beda gitu. Itu aja sih mungkin.
Iya. Oke, nanti kami catatkan, kami sampaikan. Terima kasih untuk sarannya. Boleh, masih ada waktu ini? Beli Putu? Masih ada waktu kah?
Silakan.
Oke, saya mau menyapa Ibu Siti Masruhah dulu. Assalamualaikum Ibu Siti. Halo, Assalamualaikum Ibu Siti. Apakah sudah tersambung kita? Ya, sepertinya belum tersambung nih Bu Putu. Mbak Irma, halo, apakah kita tersambung?
Iya, masih Mbak.
Mbak Irma sendiri gimana ini Mbak? Pesan-kesannya ditanya. Wah, ini.
Iya, luar biasa. Kalau saya sukanya memang suka materi yang simpel-simpel gini, lebih merakyat ya kalau QC gitu. Jadi semuanya bisa kena gitu. Jadi kalau terlalu teknis sekali mungkin hanya beberapa golongan gitu ya. Kalau seperti ini ya mungkin bisa menjangkau semua radiografer. Jadi relate lah sama kita semua gitu ya Mbak ya.
Iya, karena sepertinya banyak ditemukan di lapangan. Tadi ya, banyak sekali ditemukan di lapangan. Oke, selanjutnya boleh saya menyapa Bapak Yusuf. Halo Bapak Yusuf, selamat malam. Assalamualaikum.
Waalaikumsalam, Mbak Puspa. Ya, mumpung ada Pak Sekum di sini. Mudah-mudahan nanti bulan Juni itu.
Kameranya nggak dihidupin nih, Pak Kabit nih, kameranya nggak dihidupin nih.
Sudah, Pak. Ya, mudah-mudahan nanti bulan Juni Pak Sekum kan bisa akses ke bidang diklat. Nah, kita bisa masuk link di Kemenkes itu kan, di LMS itu, ke DKI. Mudah-mudahan pas kita jadi tuan rumah, bisa masuk link SKP. Kalau itu dijamin pasti full peserta itu. Over itu.
Amin ya Rabbal Alamin.
Ya kan kita punya Sekum termuda, masa nggak bisa masuk ke bidang diklat gitu kan. Itu sih saran saya ke depan, Mbak. Terus perlu juga nanti di link sesi berikutnya kita bisa create semacam door prize, nanti kita pilih 5 peserta gitu. Kita kasih souvenir juga yang bisa jadi kenangan sepanjang masa. Mungkin foto Mbak Puspa sama foto Pak Sekum bisa jadi kenang-kenangan. Jadi souvenir lah minimal ya. Terima kasih itu Mbak Puspa.
Ya, terima kasih Pak Yusuf untuk pesan dan kesan acara. Dan Beli Putu, bagaimana ini? Apakah yang lain mau ditanya? Sepi-sepi aja ini.
Ya, saya menyampaikan jawaban kepada Pak Kabit. Siap Pak Yusuf, nanti kita coba dengan SKP-nya Kementerian Kesehatan, semoga berhasil nanti. Yang diperlukan adalah nama narasumber dulu, Pak Kabit. Nama narasumber minimal 2 lah dulu, minimal 2, seperti tadi kan 2. Kemudian temanya, lalu kemudian ringkasan materinya sedikit, atau bisa abstraknya secara ringkas. Nanti kita masuk ke dalam proposal, kemudian kita kirim ke Kementerian Kesehatan. lewat pelataran sehat. Semoga nanti bisa dapat SKP, Pak Kabit. Begitu.
Iya, terima kasih. Terima kasih Pak Sekum. Nanti kita pikirkan materinya yang seperti clue-nya dari apa Mbak Irma tadi ya. Sederhana tapi merakyat. Nah, itu juga bagus itu. Tagline-nya seperti itu, sederhana merakyat. Jadi kan tidak terlalu teknis banget, tapi memang bisa diterima oleh semuanya. Kan ini ada 13 negara kan ini. Tentunya mungkin beda-beda pemahaman tapi bisa sama. Begitu Pak Sekum yang baik hati.
Baik, terima kasih Pak Kabit yang tampan sekali. Untuk Pak Sekup yang baik hati, selanjutnya bagaimana acaranya? Masih
Terima
mau
kasih.
dilanjutkan?
Terima kasih Mbak Puspa. Untuk absen penutup sudah bisa diisi di Linktree. Absen dibuka hingga nanti pukul 22, silakan diisi. Kemudian budayanya agak sedikit berbeda. Sekarang isian dari absensi itu semuanya essay begitu ya. Silakan Bapak Ibu kalau sudah ada register, Bapak Ibu peserta ada registernya, kemudian mengisi absensi awal, absensi akhirnya, nanti pasti dapat sertifikat. Kemudian link sertifikatnya juga sudah ada di Linktree tersebut. Silakan. Nanti ditunggu untuk yang biasanya sih 2 bulanan itu baru turun sertifikatnya dari komite pusatnya. Lalu nanti rencana kami nanti Pak Kabit Hubungan Luar Negeri itu akan kami masukkan di grupnya CPD main CPD ya. Nanti Bapak Kabit bisa komunikasi di situ. Kemudian dari salah satu hubungan luar negeri anggota bidangnya juga kami akan masukkan di tim penyelenggaranya. Jadi ada 2 grup di situ, ada tim IT dan penyelenggara, kemudian tim delegate dan para presidennya. Gitu Bapak Kabit dan Mbak Puspa update-nya. Lalu kemudian setelah ini kita akan penutupan, kemudian memperdengarkan himne Pari, baru kemudian end meeting for all. Begitu biasanya Mbak Puspa. Silakan ditutup. Bisa ditutup. Nanti setelah Mbak Puspa tutup, kita akan perdengarkan himne Pari, lalu kemudian end meeting for all.
Oke, baik. Terima kasih untuk semua rekan-rekan radiografer seluruh Indonesia yang malam ini sudah mengikuti acara ini. Semoga tetap sehat dan selalu semangat ya. Dan sampai jumpa di event selanjutnya. Radiografer Indonesia bersama sejahtera mendunia.
Terima kasih.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Lalu cantik ya seperti biasa ya Pak Kabit ya. Mantap Pak Kabit nih. Terima kasih Pak Yusuf, Pak Fahrudin, dan Ibu Isti, Bapak Ibu semuanya yang hadir. Sampai jumpa di CPD selanjutnya. Mohon izin untuk share screen himne Pari dan kemudian saya end meeting for all.